When we look at immune checkpoint inhibition in frontline treatment of lung cancer, do you see any differences in efficacy with these agents between squamous patients versus non-squamous patients?
As a single agent.
Or combination with chemotherapy? I obviously want you to review some of the combination data in squamous cell with our audience as well as we address this issue.
Yeah, I don't see any difference of IO single agent or IO combination according to histologic subtype. For IO and chemotherapy combination, especially KEYNOTE-407 study, demonstrated a significant improvement of OS, a significant improvement of PFS, and objective response rate. So this combination, pembrolizumab and cytotoxic chemotherapy, has been standard of care in first-line lung adeno as well as lung squamous cell carcinoma, regardless of PD-L1 expression. I think this make a paradigm change in our routine practice, especially in treatment-naive advanced stage NSCLC.
And as we think about agents beyond pembrolizumab, Johan, we saw the results from atezo plus carbo nab-paclitaxel at WCLC meeting recently. There was a PFS benefit. Talk about the survival data from that trial.
Yes, well, there was, as you say, there was previously reported there was a PFS benefit. So the overall survival data from that trial point at superiority of the combination of atezolizumab and chemotherapy in patients with very high PD-L1 expression. So the biomarker used in these type of trials is the combined tumor cell and immune cell score by the SP142 antibody, which is perhaps not the best antibody. But those who had a 3 in immune cells or tumor cells, they had a significant benefit in overall survival when you added atezolizumab to combination chemotherapy. Those who were in 2 did not achieve a significant overall survival benefit. And then because of that, there was a hierarchical testing in that trial. Because of that, the ones that came at the 1 were no longer tested. So it's the PD-L1 high patients that seem to derive benefit when you add the atezolizumab to the backbone of carboplatin and nab-paclitaxel.
So at this point, for PD-L1 positive patients, regardless of low or high positive patients, we can't just say use chemo plus atezo. For those patients, probably chemo plus pembro. And if you have the highest positivity, that could be a consideration for using chemo plus atezo.
Yeah.
Or single agent pembro.
Or single agent pembro.
Yeah.
So let me touch on that, Pasi. You bring up single agent pembro. Who do you give single agent pembro to in your practice now?
Yeah, I think it's an interesting point, because I think the option is to give if you're greater than 50% PD-L1, you can give single agent pembro or you can give pembro chemotherapy. And I think there's some subjective decision making that goes into that. So for example, somebody who really needs a response, meaning that their disease is central, they're about to block off an airway, things like that, I think you want to give both to give the maximum likelihood of having a response. Somebody who has low burden disease, elderly patient, I think I would be more inclined to start with a single agent pembro as opposed to combination chemotherapy to avoid toxicity and not being so urgent in terms of the disease. So I think there's some subjective decision making that goes in there, even though both are technically options.
And that is also related to the fact we have quite a lot of trials now comparing immunotherapy and chemotherapy, usually in PD-L1 high. We have trials comparing chemo plus immuno versus chemo alone, but we don't have the trials comparing immuno alone versus chemo plus immuno. And so therefore, of course, there is a certain subjective factor in it.
So Johan, to that point, I'm happy to say that in the US, there is a cooperative group trial led by ECOG Akron that compares chemoimmunotherapy versus immunotherapy followed by chemotherapy at the time of progression, which will help us understand
Very important,
the
yes.
sequencing question.
And I think that brings up another interesting question there, you know, and I assume that's in the greater than 50% patient population?
That includes
no?
both greater than 1% and the greater than 50% population.
Right, I think that, because what happens if somebody starts with, and the question that will be answered there, if you start with IO and don't respond, how well does chemo do there, or do you use chemo IO in that situation, right? So I think these are areas that we lack a little bit of knowledge.
And this trial has 3 arms to answer just exactly the issues that you bring up. So
excellent.
We look forward eagerly to those results.